webinars, for third full year of webinars. We got an exciting program for you this year. We've changed the format over the 3 years that we've been doing it, and I hope you like our present format. If you have any comments about our format or what we're presenting or what you'd like to see us present, then please drop us an email afterwards, and there will be a clear, obvious space to put that in. After the webinar tomorrow, you'll get an email asking you for some evaluation. If you fill out your evaluation form, then we are able to send you you can then download your certificate for attending, which is really useful. Whilst we go along, if you can pop any questions that you have into the Q&A section on Zoom, and we will either read them out at the end of the person who's just given the talk and let them answer, or if they come later, then we will either type you something or we'll stop at the end and talk about all of our answers there. Today's webinar will be on endoscopic treatments for hydrocephalus. It's something that all of us are seeing all the time across the world, and we're really very blessed to have 3 amazing speakers with us today, and we're covering most of the whole of the world. We have North America. Ashley's going to speak to us. Norbert is going to speak to us from East Africa. He's in Uganda. And Kylie also is going to speak to us, and she's speaking to us from Perth in Australia. So with nothing more to say, I would like to introduce Ashley. She's our present chair. She's one of the advanced nurse practitioners at Boston Children's Hospital, and she is going to speak to us about ETV and CPC and how it's done and why it's done. Over to you, Ashley. Thank you.
Thanks, Jen. Just gonna share my screen. Okay. Sorry. Start at the beginning. So like Jenny said, I'm Ashley. I am from Boston, Massachusetts. I'm a nurse practitioner there, and I work in just in pediatric neurosurgery. So my portion of the talk today will be to discuss kind of the introduction to ETV and ETV with CPC, the history, why we do it, and where it came from. So first, I just want to talk about why nurses need to understand endoscopy, ETV, and CPC. You might be saying, like, this is a surgical, like, we're talking about just a surgery. Why is this important? Well, hydrocephalus management is changing. It's changed a lot in the last 20 years. ETV patients behave differently than shunt patients in the way that they fail. And a nursing assessment is critical and central to detecting whether or not this procedure has failed. There are a lot of myths out there. People think that this doesn't work for various reasons, or there are reasons why people aren't doing ETV or ETV with CPC. So it's important that we're all informed of all the treatment options so we know what we're dealing with. So just very briefly, just because we're going to all be touching on this, I wanted to talk about brain anatomy and particularly what's most important when we're talking about endoscopy. So the brain has ventricles in it. They're deep in the brain, and they're 4 hollow cups, essentially, with passageways between them that contain cerebral spinal fluid. They open into the central spinal canal and the area beneath the arachnoid layer of the meninges. And there are 2 lateral ventricles, and then you follow down to the 3rd ventricle and then the 4th ventricle. And then I hope we all know this, but just to recap, what is hydrocephalus? Hydrocephalus is a disorder of the CSF resulting in abnormal enlargement of the ventricles and usually associated with increased intracranial pressure. So you can see in picture A, those are normal ventricles, and in B, those are humongous ventricles with capping around the ventricles, indicating that there's pressure, that there's hydrocephalus there. And what is cerebrospinal fluid? So it's a clear, watery fluid that surrounds the brain and spinal cord and helps cushion, protect, and nourish the nervous system. CSF production is mainly from the choroid plexus, but it also comes through the outside of the brain. Around the outside of the brain, there's CSF coating there and being produced there. And there's absorption of the CSF through arachnoid granulations. The ventricles are not the only place that CSF is produced. And I say this, you'll find out why I say this again, because it's important later. So that little diagram just shows you the flow of CSF, how it's supposed to come from the ventricles, go down through the ventricles, coat the spinal cord, and come around the brain as well. And it's circulated constantly around the surface. There are different types of hydrocephalus. So there's congenital and acquired. Congenital is about 55% of all cases. Acquired, and then there's acquired, and this for some reason didn't split this up better. But then within congenital and acquired hydrocephalus, you can have communicating or non-communicating. And the thought that communicating is when CSF flows freely, but for whatever reason, hydrocephalus still develops, and that can be in acquired forms such as meningitis, which means you get it later. So meningitis, it can happen because of a hemorrhage, trauma, or non-communicating or obstructive. So you have aqueductal stenosis, and you can't circulate your CSF the way that you're supposed to. Rarely, hydrocephalus occurs because of overproduction of CSF. That's a really rare form of it. But the most common causes really are infection, Chiari related to myelomeningocele, tumors, or different neural tube defects. So why do we treat it? Why is this even important? It's because hydrocephalus causes damage and inflammation to the brain, and it impacts brain development. And the ventriculomegaly itself, right? If you have big ventricles, you compress the brain, it doesn't allow for it to grow. So historic treatment of hydrocephalus is that we use shunts. That's basically the standard of care. Everybody's going to tell you that shunt is the way to go. But there are problems with this. It creates a dependence on a device. The shunts that we use today basically were developed in the 1940s and 60s. They really have not changed much. Once people just figured out that it worked, they just stuck with what worked. So, and then silastic tubing was invented. And once that was invented, that was a game changer. We really stopped doing anything else. And we were able to dump CSF in various places in the body with a tubing that was inert. The body didn't attack that tubing. But half fail within 2 years of placement. Every patient has an average of 3 revisions per their lifetime, but we all have seen the cases of the 20-something revisions. 5 to 15% of shunts will have an infection, and that's usually in the 30 to 90 days after they have had a shunt surgery. It's also an enormous cost to put in shunts, and it's become big business. It generates money for people. So this is what a shunt is. You probably all know this, and you've probably all seen this diagram before, but you have your ventricles, and then you have your ventricular catheter. You have a valve of some sort, and that connects to another catheter that tunnels under the skin and empties mostly into the peritoneal cavity. But the more shunts we have, the more problems we have, right? There's mechanical failure, broken valve, broken catheter, blocked catheters, there's infection, and there's a need for immediate access to surgical care when there's a failure. And this is especially a problem in resource-limited settings. You have a shunt malfunction, you have to get to a hospital immediately, or you can die. So why did neuroendoscopy emerge? To avoid implanted hardware for all the reasons that I just mentioned, to try to restore CSF pathway to the way it's supposed to be, to treat obstruction rather than bypass it and just put the fluid somewhere else, and shunt problems. That's why. What is neuroendoscopy? So it's the use of an endoscope to visualize ventricular anatomy. It allows for direct treatment within the ventricles, and it's the foundation for ETV and CPC. And there are different types of endoscopes that we can use, flexible and rigid endoscopes. The first ventricular endoscopy was in 1910, we think. It was a guy, this man, Victor Darwin. I'm not even going to try to say his last name, but that's him. That's a picture of him at the top. He used a cystoscope, and he did this on 2 infants, and he didn't publish his work. And then we first see it published in 1922 by Walter Dandy, and he talked about cerebral endoscopy. And that's Dandy, and that's his picture from what he did. What is endoscopic third ventriculostomy? So it's a creation of an opening in the floor of the third ventricle. It bypasses an obstruction, and it restores CSF circulation. So you go through the lateral ventricles into the third ventricle, and you poke a hole, and you allow for the release of CSF. The first ETV in the 1920s, 1923, Mixter at MGH used a cystoscope, and he published this case study where he did this. He was at Mass General in Boston, And then we don't see this mentioned again until the 1970s. It was performed as an open procedure initially. When it was performed, it was used for obstructive hydrocephalus only, and the outcomes weren't great because of the method. And then in the 1990s, interest increased again, and people started doing it in a better way. And those were in the 1990s. That's the first time we see it published since the 1970s. It's very different from what we do now. Kylie will talk more about the OR and what we do, but it's a small incision now. The endoscope enters the ventricles from the lateral, just lateral from the midline and just behind the coronal suture. It's a small entry point rather than something big and open in the back. And the endoscope moves from the lateral ventricles to the floor of the third. And now we also use flexible endoscopes. So everybody uses the ETV success score, right? So this is how you determine if somebody is actually eligible to get an ETV. You look at age, etiology, and the history of previous shunt. And this score is not fully predictive for those who are eligible for CPC. So we can use it for ETV, but we're finding with the little babies, this isn't as useful because the success rate increases when you add the CPC for those under age 1. As we do more of these procedures, we know that age is actually the biggest predictor of success. When ETV alone is most effective for obstructive hydrocephalus, for favorable anatomy, and for children greater than 1 year of age, and for adults. So I mentioned CPC and choroid plexus, but what is choroid plexus? It's the tissue in the ventricles that produces CSF, and that's a picture of it right there. The first CPC is mentioned in 1934, and it's another Boston guy. And he did it in 8 infants, and that's him, and that's his paper. He used it for communicating, so-called communicating hydrocephalus. He had reasonable success. He thought that it reduced CSF production, but again, because the technique wasn't great, neither were the outcomes. And now we kind of come to modern day treatment. So the first ETV with CPC was done by Dr. Benjamin Wharf, who works with me here in Boston at Boston Children's. He traveled to Uganda to start a pediatric neurosurgical hospital with Cure in 2001, and he was treating hydrocephalus with shunts, and he realized he was creating a dependence in children who don't have access to emergency care. A flexible endoscope was donated. He did a lot of research about neurosurgical history and found information about the guys I mentioned before. And he started with the ETV because he didn't want to shunt, but he realized that it was failing in infants. And that's where most of the cases were in infants. So he published his first study, and there it is there, talking about doing ETV with CPC. So we think that by adding CPC to ETV, it helps infants because infants produce relatively more CSF. It reduces the CSF burden while absorption matures. We think as you get older, you absorb CSF better. We think that infants have more compliant brains. They're really able to push out their ventricles when the pulsations are big. They make big ventricles. And we think that CPC reduces the pulsations in a young brain. And we also think that ETV might be a pulsation absorber. It improves the ETV success in those populations, so in under 1. So just to reiterate, ETV alone is more successful in older patients. ETV and CPC together are more successful in infants, and the decision on the type of treatment is dependent on the patient. This is really important when we think about the global importance of endoscopic treatment. So fewer emergency revisions if you have an ETV, reduce the burden on the system and also the risk to the patient. It reduces hardware dependence. We have about 400,000 infant cases per year, and half of those are in sub-Saharan Africa. And there's only one neurosurgeon per 2 to 7 million cases. So there's a high impact in a low resource setting where access to care is limited, and it's more cost effective. I love this slide. I stole it from Dr. Wharf, but basically it just goes to show you that it's a better global health public strategy, right? So if you break this down, you see that you have less complications, less surgeries, and long-term kids have less to worry about. So ETV, endoscopic treatment, is the way to go, especially in limited resource settings. Oh. And then again, just talking about the ETV success scores and the outcomes. So we know that children that were less than a year did better with ETV CPC. We know that the cause matters somewhat, and that kids that had myelomeningocele really did the best, and especially when we added the CPC. And then the graph, I think, is really helpful because it shows that even though ETV might fail up front, we're paying attention to failure rates up front because the greatest risk is that it fails within a year. Once you hit that 6 month to a year point, you have success less than 1% fail. And shunts continue to fail over time. So the line that's going down is shunts just keep failing and failing. So etiology really doesn't matter that much in infants. You can redo an ETV if an infant closes over their ETV opening. And the success rates are reproducible. We know that people from different places can get the same outcomes that we got in Uganda, where there was high impact in one high volume and one surgeon. We know that ETV CPC is just as good for brain growth and development. So we've done a lot of developmental studies, and kids who had an ETV and CPC do just as well as the kids with shunts. And ETV is more cost effective. And the most common cause of failure of ETV in infants is closure of the ostomy. And again, we know once we add the CPC, for the kids under 1, success rate increases dramatically. We know that it can prevent shunt dependence in about 2/3 of children, which is huge. And like I said, ETV becomes 15 to 25% more successful once we add the CPC. And these are just the outcomes that we've seen now. One important thing to remember is that the symptoms of hydrocephalus are the same symptoms of ETV failure. So rapidly increasing head circumference if they have an open fontanelle and sutures are not closed yet, vomiting or poor feeding, increased irritability, increased lethargy, a full and bulging fontanelle. They have headache if they can tell you about it, or they seem like they're in pain. Abnormal eye movements, especially forced down gaze. So those babies will look startled and have white above the tops of their eyes. And then the key nursing takeaways for this is that there's no hardware with ETV. We're not putting anything in your brain. So there's less risk of infection and there's no chance of mechanical failure later. The infection rate with ETV is very, very low. Imaging does not define success. So ventricles stay big. They're going to look at imaging later. And we found out that actually doesn't matter. What matters is compression on the ventricles. Clinical assessment matters most. So nurses are vital in this and talking to families and with patients to see if they're having any symptoms. Symptoms in children who had very progressive hydrocephalus after they get the ETV can resolve slowly after treatment. So you don't always have an immediate fix. Failure symptoms are the same as hydrocephalus. Nurses need to look out for that, but sometimes they also occur more slowly. They don't happen right away. The child gets better initially, and then they start to get pukey again, or they start to get irritable again, or they start to have headaches again. Recovery is easier from this surgery from a shunt. So they feel better faster. It's smaller incision. It's one incision. It's not tunneling the tubing down, and you don't have to worry about things as much. But follow-up is more important. The greatest risk of failure with an ETV is within the first year. So you really have to keep an eye on these patients because it's a real risk that they could fail. Results show that this treatment is just as good for a growing brain. Failure risk after a year is about 1%. And the most common cause of failure is closing the ETV, but we can reopen it if a child had success for a while. And so now, after my rapid fire presentation, we're on to what happens in the OR. And so Kylie will explain that to you. And I think this is important because understanding what happens in the theater helps us give better bedside care. If we understand what's going on, we're able to better explain it and understand things for the patients and the families. Thank you.
Just before we move to Kylie, there is one question for you, please. Moana Dea, I'm sorry, I've probably pronounced that wrong. I do apologize. Asks, what success score gives the surgeon a go-ahead on performing the ETV?
So you can use the ETV success score that I showed you to determine if a patient has a good chance of being eligible for this. At major centers, ETV is really just our first line unless anatomy is very bad or really that's really it, or they're very, very young. But what we have found is that you add the you add the CPC in those kids, and what matters is age. Age is the biggest predictive factor. So you use the ETV success score, but when the CPC, you know that if they're under 1, then their success rate is higher.
Perfect. Thank you very much. That was a great talk, Ashley. Thank you. We're going to move on to Kylie now, who's staying up before she goes to bed late at night. Kylie is one of the clinical nurse specialists in pediatric neurosurgery down at the Perth Children's Hospital in Australia, and she's going to talk us through what happens behind those closed OR doors. Kylie, over to you. Thank you.
Thank you. Well, now I've got to. Has that worked? Is that right?
Yep, you're good.
That's
Okay,
good.
good. Just wanted to check that it was right for everyone else. So good morning, good afternoon, and good evening to everybody from Australia. So I am the clinical nurse specialist for neurosurgery at Perth Children's Hospital in Western Australia. And I was previously a theatre nurse doing neurosurgery. So I'm going to have a chat to you about this, actually my favourite procedure of all neurosurgical procedures. So in the operating room, I don't know how many of you are theatre nurses, but I'm just going to talk to you as though you know what I'm talking about. So the setup for the operating room remains the same in most ways. So you still need an operating table. You need appropriate head fixation with clamps and pins for an older child, and horseshoe, headrest, and gel pads to replace the pins if they're under 2 years of age. And this is to make sure that the head is stable and doesn't move during the surgery. For an ETV, you still need things like a shave trolley and equipment to shave hair. You need suction, diathermy. You need your neurosurgical specialty equipment. You still need a drill because we're going to do a burr hole in the skull to get into the brain. You still need prep, drapes, and neuronavigation for trajectory planning. This will be surgeon dependent. Some will want this and some will not. And I'll show you why in a minute. So what's different about neuroendoscopy? Well, there's lights and there's camera and there's a little bit more action. So there's a few added extras for neuroendoscopy. So you'll need a scope, an endoscope, which is a specific type of scope for this procedure. You need a camera to be able to see. You need a light source because we're putting that endoscope into a deep dark hole. You are going to need fluid and you're going to need lots of it. At Perth Children's Hospital, we always keep 4 litres of IV ringers in our fluid warmers. If I was ever to find out that we were doing an endoscopic case, because we don't do them regularly, I would add 6 litres of IV fluids to the warmers the night before. So there was plenty of fluid and there was never a problem with that. One of the most important things you'll need is a peel away sheath and a stapler. So on the right-hand side there, you can see that, and that's basically your port. So if any of you have ever done any other sort of endoscopic surgery, so knee surgery or abdominal surgery with scopes, then you know you need a port. And this is your port for neurosurgery. It peels away on the side there and it gets stapled onto the skin, and that then gives you an access to the brain. And of course, you still need your basics for surgery. You need a scalpel, a drill, suction, and diathermy. So these are what the scopes look like. So on the left and the right, you've got a 0-degree scope on the right, and you've got a 30-degree scope on the left. My surgeons at Perth Children's Hospital prefer 0-degree because they don't like to be disorientated by the change that a 30-degree scope can give them. This is part of the insert. So this scope goes inside this, and then the fluids and everything gets attached to that. This is the extra equipment that you need. So this is your bipolar cable. This is the piece of equipment that dilates and makes the hole in the floor of the third ventricle. These are your different types of inserts, and your diathermy that is over here, and a few other bits and pieces. At Perth Children's Hospital, we use Storts. I don't know what people around the world use, but it's a very common endoscopic camera to use. It's got a very good quality and gives a great picture. So this is the camera that gets attached to the end of the scope. And then when you've got your flexible endoscope. Now, I am going to be talking about CPC, but we don't do it at Perth Children's Hospital. And in talking to some of my consultants, they're reluctant to do it, and I'm not sure why, but we'll get we'll move on from that. So the stack, that's the next piece of equipment that you need to make sure is in the room, and the screen must be seen. So the position of the screen and the stack is dependent on the availability and connectivity of your operating theatre. If you are able to connect with technology to other screens that can be pulled down over the patient, then this stack can be behind the surgeon with everything plugged into it and the image projected onto a screen in front of them. If not, then this stack needs to go beside the bed or at the end of the bed so that the surgeon can see the screen. Without being able to see that screen, they can't operate at all. This is all partly surgeon preference, so we are able to connect to fancy screens, but some of our surgeons still prefer it to be on the side of the bed. It's whatever works for the surgeon and whatever works for the operating theatre you're in. And now all of that is before we even start. So then you've got your different roles within the theatre. You've got a scrub nurse who's going to set up the scope and leads and make sure everything works. They're going to make sure they've got everything that the surgeon needs. You're going to count, prep, drape, and get the scalpel ready. There's the unsung hero in the operating theatre, the circulating nurse, who will open the equipment, check everything that's required, help position the patient. We always keep the baby's hair when the surgeon shaves. It's often a baby's first haircut, and the parents really like to have that hair. We do a count, team timeout, plug everything in, hang the fluids and keep them coming, move everything into place and start the documentation. The surgeons, well, what do? They come in, they'll have a bit of a banter, but if you notice what they're doing, they're actually having a good look over the equipment at the same time. They position the patient, stabilize the head, shave, prep, do team timeout, scrub, drape, and then I don't know what happens in other centers, but all of my surgeons put their hands on the scope, run fluids through it, and make sure everything is working the way they want it before they start. Then they plan the trajectory. So that it's all about the trajectory. They're using a non-flexible scope unless they're using flexible, but mostly it's a rigid scope. They're aiming to go through the lateral ventricles, through the foramen of Monro and down to the floor of the third. Because it's a rigid scope and they're in the brain, once they're in there, they can't move from side to side. They have a small burr hole in the skull up here. They're going through brain tissue and they cannot move around. So they have to get that angle right. And here's another shot of it. So this is CSF. You can see aqueduct stenosis there. And this is the floor of the third ventricle that they're aiming for down here near the pituitary stalk. And this is what it might look like. Certainly this is actually from Uganda, this shot. And every operating theatre will be slightly different, but the basics are the same. So this is the scope. This is the burr hole. They're putting the scope down in through there and getting ready to go. So what will they see? I'm using this diagram here on the side again to look as you're going through the foramen of Monro that you can see over there. This is what you're looking at. And this here is choroid plexus, and that's why I love this procedure so much. It's the only time you ever get to see it in action. So this is your foramen of Monro at the floor of the lateral ventricles going through the third. This is the floor of the third ventricle. Here you've got mammillary bodies, and straight behind here where I'm pointing is your basilar artery. So you're in dangerous territory right now. So this is another shot of it all. So this is going through the foramen of Monro, the floor of the third. This is the tip of the dilator going there. They put a hole into the third ventricle, the floor of the third ventricle there. You can see it's a very fine web. Then they dilate a balloon. So some people use a specific balloon. Some people use just an embolectomy balloon. They dilate it in that hole, and then this is the hole that you're left with at the end. And you can see through the floor of the third, and often you can see the basilar artery pulsating behind it. CPC. So if they're going to do the choroid plexus cautery, you're going to bring in the flexible endoscope for getting around the corners. It gives you an amazing view around the corners. You have to poke a hole through the septum pellucidum so that you can get through into both lateral ventricles. And the aim is to cauterize as much of the choroid plexus as possible in both lateral ventricles. And this is what the cautery looks like. So again, that's your hole in the floor of the third here. And in these other pictures, you can see that the choroid plexus is changing colors. And that's it being cauterized and the blood supply of it but dying off and going away so that it becomes unable to produce CSF after that. So what could possibly go wrong with sticking a straight scope straight into the middle of the brain? If the patient has unusual anatomy, it can make it very difficult. If poor planning and poor trajectory is what they find, then they can have a lot of trouble getting through the foramen of Monro. And I have known they've had to come out and restart the whole procedure. The biggest problem is bleeding. If the patient starts bleeding down that deep dark hole in cavities full of fluid, it is very, very hard to stop that bleeding. The whole view that they get will be gone. It will all be just covered with blood. And really, the only way to clear that is a lot of fluid, which is why I always have at least 10 litres of IV fluids ready to go. And the other problem is equipment failure. Once you start, you don't want anything to be breaking down or not working the way the surgeon wants it at exactly when they want it. So once the patient's finished, once they've finished doing their third ventriculostomy and their CPC, if they're doing that, then you just close up, do your count, and start thinking about the patient leaving the theatre. In terms of post-op follow-up and for the nurses that are being handed over to, they need to be making sure they're doing close neuro-obs for at least 24 hours, monitoring temperature, pulse, blood pressure closely post-operatively, watching for a CSF leak from the wound because we've had a direct access into the ventricle and basically all that's stopping it is a few sutures, and to report any changes in neurological status to the neurosurgical team. And the last shot I'm going to show you is a post-op scan after an ETV, and you can see where that arrow is, that you can see fluid going through the floor of the third ventricle to allow it to go out and to be circulated around. That is it. That's all I've got to say. If anyone has any questions.
Oh, just looking, there is one question just come up. Oh, she's written it in French.
Oh, no.
Okay. Zeus, let me see. What's the space? What's the pathway? I think that they're asking, please, I hope someone's better at French than me, but I think they're asking what do you use to ensure that you don't hit the basilar pre-op?
Nothing pre-operatively. During the surgery, they're basically looking at the floor of the third and examining it first. They know where that basilar artery runs, and it's between the mammillary bodies, straight under the mammillary bodies, under the floor of the third. So they go forward of that, and they go very gently. And they don't poke it with anything rigid. It's poked with the dilating balloon, the tip of that dilating balloon, which is I can't remember what French diameter it is, embolectomy balloon.
I think Ashley also is going to say something. Ashley, would you like to speak?
I was just going to say, I know we talk a lot about like the risk of basilar artery injury, but it's much lower than we all talk about. It's just that people have been very traumatized because it's very scary if it happens. And when you use the flexible endoscope, it's even less of a risk. But I just wanted to like because everybody's always afraid of basilar artery injury, but you know, it's very, very rare. But yeah,
and don't forget that the basilar artery is actually pretty tough, and the equipment we're using it very gently, and it's very fine and quite flexible. So yes.
If my schoolgirl French from 50 years ago was not good enough, then please somebody write it in English for us, and we will represent it if I didn't understand what the question was, and my apologies, obviously. So thank you, Kylie. That was really fascinating, and gives us a nice little swish round OR for those of us who don't go there regularly. These things happen and then the patients come back. I'd now like to move on to Norbert, Norbert is joining us from Uganda, and he is going to speak to us about post-op care of children who've had ETV and CPC. So Norbert, thank you so much for joining us today, and over to you.
Thank you very much, Gina. My name is Norbert Mzahura. I'm the clinical coordinator with NeuroKids at Mulago Hospital in Uganda. We're going to look at the nursing, post-operative nursing care for ETV CPC patient. Our main objectives today, we are going to look at the expected postoperative finding, recognizing early and late complication, and also how we can effectively give discharge education. When we receive a patient from theater, it is really important to get comprehensive reports, both surgical, anesthesia, and from the recovery unit. These would highlight what they have done, what complications, the events that have taken place within the time the patient was in theater. Also, you need to do a comprehensive head-to-toe assessment. Particularly, you need to look at the incision site and also do a neurologic assessment to know the level of consciousness of your patient. The head position, elevation, about 15 to 30 degrees. This would help to keep the integrity of the stoma and also prevent CSF leak through the incision site. It is really important to keep monitoring the physiological state of your patient, so vital signs can easily give us quick alerts whether our patient is doing well or we need to advance care in well caring for this patient. Head circumference and fontanelle in infants, we are going to look at that in the next slides. Input and output for this patient is really important. You heard from Kylie that they use quite a lot of fluids, and remember, this patient has been fasting. The other thing that the patient has been on NPO for quite a long time. You need to really get a comprehensive report on the IV, on inputs and output. Also, you need to make sure that the IV access for this patient is patent as you're caring for for the patient. In measuring the head circumference, we use the flexible measuring tape, where we measure the largest circumference above the eyebrows, ears, and also around the neck. It is important to use the head circumference charts to note down the value you've got, which could add more sense to your value. The fontanelles are spaces where two sutures join and eventually make a membranous covering on top of that. And we have two fontanelles, the anterior and the posterior. Normally, we assess this to know what is happening to the patient. We can see it is sunken while the patient is dehydrated, and this could be carved in and below the bones of the skull. In the normal patient, normally it is flat, and when it is bulging out or curving outwards above the bones of the skull, it indicates that there is quite a lot of pressure within the brain. ETV, as we heard from the previous presenters, that it relieves pressure from the brain. And this is not an off and on switch mechanism, but it has a gradual improvement that it brings to the patient rather than immediate. So you register some mild headache, and irritability, some nausea and vomiting. Also, the patient might have initial trouble while feeding. When you look at the images, there might not be a really immediate change on the imaging. The early complications, we have CSF leak, we have bleeding. This could be intra-op bleeding into the ventricle. You need to read the surgical notes and understand what the surgeon did and how he has commented, whether it was mild, moderate, or heavy bleeding. Because we use a lot of fluids in the OR, we are likely to have electrolyte imbalance. Hydration could be attributed to poor oral intake or the NPO that we had. Fever is likely to be there because of the meningeal irritation or infection. In late postoperative care, we could register complications like stomach closure or subdural hematoma, endocrine hypothalamic dysfunction. Whenever there is a damage or injury or disturbance on the hypothalamic pituitary region, we are likely to get this, maybe preconscious puberty and so on. Also, we have children who have had seizure disorders. The failure symptoms are more like the signs of increased ICP in these children. And one of the few I could note from here, we have bulging fontanelle, we have abnormal eye movement. The eyes may appear to be looking down, what some people call sunsetting eyes. We have delay in milestones, and in or spina bifida children, we may have issues with breathing. On ward, the care might not be so intense like the ICU or HDU, but still positioning is quite important. And we need to advance on feeding. Remember, we have had children who, because they are disturbed with pressure, they have not been feeding well, they have been vomiting. Sometimes they may resort to the protein that they have already, or the little fat they have already built on their body. So we need to really encourage the mother, or involve the mother, encourage them to really feed. Irritability as one of the signs of failure can also be attributed to pain. Pain management is key in the care for these children, and also close monitoring the level of consciousness in the ward is key. Infection prevention, as we all know, that hospital-acquired infection can cost a lot, both on the patient and the hospital, and even the staff. It is really important, whoever comes into contact with the patient, be the nurse, physiotherapist, the doctors, and the surgeons, all of them need to either wash hands or put on gloves, to say the least. Parent involvement is very, very, very important. This could start even on admission. We could start parent involvement. They need to know what is going on with their loved ones, so that if they have questions, if they have worry, if they observe anything that is really happening on their patient, they could easily report or ask, so that we could allay anxiety and also have good time in the during the hospitalization. ETV is different from shunt, or you heard from Ashley. There is no implanted hardware. Different timelines for failure. We have early and late failure. ETV might require more frequent follow-ups, so that we can diagnose the failure or the functionality of ETV as early as possible. They may require a lot of education concerning what the patient is going through, what they have done, and what they anticipate in the future. All this has to be done, more especially for the ETV patients. In the follow-up, incision site check is quite important, and you need to really understand that it can be infected. They can come back with a CSF leak, or it may be bulging. So they need to really come out with you need to really follow up on this and check whether the incision site is right. You also need to reassure parents that they might have short interval for follow-up, since failure might be early or late. The imaging, they do a lot of imaging compared to the shunt. So at 3 months, 6 months, and even annually until they are 5. Education is quite crucial in this category of patients, where we need to let mothers know, because at a point where they are not with us, they are our eyes and ears. So then you need to teach them all the red symptoms, when they can seek care urgently, and you need to reinforce that ETV can fail. Either they come back for a redo or any other treatment. Care at home in low resource setting. Of course, the education has to dwell more on the symptoms, the head circumference measurement, and vomiting, and fontanelle assessment, and more others. However, since the ETV failure might be slow than the shunt, which might be an emergency, you need to involve mothers in the monitoring so that they could really attend appointments in real time, report all the complications or what they have observed, even consult the nearby health facilities where they can get real care and timely care. When to escalate care on ward, all features that of increased intracranial pressure need to be registered and need to be discussed by the team. As after discharge, you could encourage mothers to report when there is rapid increase on head circumference, bulging fontanelle, when the baby has started vomiting, or if it continues, because we see that postoperatively it might be there, some vomiting might be there. If the baby is lethargic, or you have to arouse them so that they can feed, all this has to be reported, or they need to escalate care. In Africa, where we are, there is a lot has been done, and great people have really contributed to the resources that are available. However, we still have limited imaging availability, which is really quite expensive for some of the parents. And we have delayed and lost follow-up. This could be attributed to the poverty that we find in some of the families, and reliance on caregiver observation may be subjective. There is limited nursing education in training schools about these conditions and how we can properly manage the conditions. Community awareness is key to improve the outcomes of these surgeries. However, it is still inadequate in our community. Point to note, ETV success depends on ongoing assessment, both at the hospital and even at home. Failure may be delayed. That is one thing that need to be clearly noted, and nursing education saves life. Thank you very much.
Thank you, Norbert. That was really interesting. And for me, it just reminds me, in the West, we don't have as much concerns about underweight children who haven't been able to feed because of their hydrocephalus. But I think it's something that maybe nurses forget, that early feeding is really important for these kids. Get them back to feeding well, so that they can be putting on weight and growing normally, because they have so many other issues going on in their head. So that was a really good point. Thank you so much. We have one question in the Q&A. Thank you guys for putting up some questions. Kylie, this is one for you, if you could pop back on, please. What fluid do you use in irrigation during ETV?
We use IV ringers.
Perfect. Thank you. I hope that answers your question. That was one of the neurosurgeons from Bangladesh was asking us that. So now, just to finish off, we've got about 11, 12 minutes to finish off. We're just going to run through a few case studies. Ashley's going to run through some case studies just to illustrate everything that we've talked about today. And then we'll be wrapping up. Please bring your other questions if you would like. Oh, there's one more question. Hold on. Oh, no, that's
Wait, Jen, let's go through this. We can answer them at the end.
Yep.
All right. So I'm just going to run through these really quickly. So the first patient is a 6-week-old patient, diagnosis of myelomeningocele, repaired day 1 of life, found to have hydrocephalus. The symptoms were rapid acceleration of head growth. There was a full fontanelle. There was lots of spitting up, both with and after feeds, and they were slow to wake up for feeds. Infants should really wake up to eat, right? And they weren't waking up to eat. So initially, you can look at the ETV success score. And if you do it this way, then the age Less than 1 month, you get 0 points. The 1 to 6 month, they get 10 points, which is where they fit in. 6 to 12 months, you get 30. The etiology is myelomeningocele. So if you look at that, you get 20 points just from that. And then if you had a prior shunt, you lose points, but you get points if you didn't have a shunt, so 10 points. So the total score is about 40% chance of success. But once we've added the CPC, we know that this isn't as important, and age is actually the most important predictor. But so if we use a success score, we say it's about 40% chance of success once we follow up at 6 months. But you add the CPC, it's about 15 to 25 more points. So the success is probably around 55 to 65%. And the nurse should educate the family about signs of failure, and as well as what monitoring will look like. So all the things that Norbert talked about. So on the post-op course, the child had mild irritability on post-op day 1 with some nausea and vomiting. That resolves as the day progresses. It's really common for kids who have had an ETV CPC to have nausea and vomiting. I tell families that all the time, that not to worry. We only worry if it persists and it doesn't stop, or if they're not able to tolerate their feeds at all. The fontanelle is softer, but it's still full, and their feeding is slowly improving through the day, and no routine imaging was performed. Which findings are expected after ETV CPC? So we talked about this, that sometimes you'll have nausea and vomiting that persists. You might not have any change in your scan. You might, because some CSF is let out in the OR. So if you get an immediate post-op scan, you might see that the ventricles are smaller, but you might not. What would concern you in the first week? So like I said, if vomiting persists and they're not able to tolerate any feeds, we would worry about that, or any progression of any of their symptoms, but a little bit of lingering of the symptoms wouldn't be as concerning. How does this differ from a shunt patient? So the shunt patient would have multiple incisions, and if they are really sick right away, you would worry that there's something wrong with the shunt, that it's not working. And then all the things that we've talked about that would be taught. So for patient number 2, this is a 6-year-old with hydrocephalus. Symptoms of headache, morning vomiting, and they all started within the last few months. So getting headache that's getting worse and worse, some morning vomiting. Every morning they would get up and throw up, and then they're now sleepy. They're not really doing what they were doing before. They had an exam by an ophthalmologist, and they had papilledema, which is swelling on the optic nerve, and it's a sign of hydrocephalus. And they have no neurosurgical history. This is a healthy kid. So you get an MRI and you find aqueductal stenosis and you find hydrocephalus. So in this child, you can just use the ETV score alone, right? So they're older than 10, so they get 50 points right off the bat for that. Aqueductal stenosis, they get another 30 points. They've had no shunt, another 10 points. So we know it's about a 90% chance of success with an ETV, and they don't need a CPC because they're older than a year old. Oh, okay. So the first post-op visit, they're discharged home post-op day 1, the headache's resolved, and they're tolerating their diet. When they're seen at follow-up at 6 weeks, the symptoms have resolved. The papilledema is improving, but it's not yet gone. Papilledema takes a while to develop, takes a while to resolve. They're back to school, they're playing sports, and they have stable ventricles on their MRI. Important questions. Which findings indicate into ETV success? So symptoms have resolved. The papilledema is improving, and they're feeling better. Why is ventricular size alone insufficient? We know that ventricles might not get smaller. What nursing assessments are crucial in follow-up? You want to look for the symptoms that the child had before. If they're persistent or recurring, then you would worry about that. And we know that the biggest predictor of success for this patient is that they had a clear obstructive hydrocephalus with aqueductal stenosis. So we know that if we give them a new way to get rid of that CSF, then we can cure this problem. And the last patient is a 3-month-old. This child has post-infectious hydrocephalus. They had a history of, they were premature, and they had a history of neonatal meningitis. They have not had a shunt. They've had progressive ventriculomegaly and increasing head circumference. They have a huge head, and they're progressively choking and spitting up with feeds. Mom's like, they're not really latching. They're really irritable, and they're spitting up and choking when we're trying to feed them, and they weren't doing that before. Can they have an ETV? So like I said, this is a little baby, so this success score is not as important, but they're 1 to 6 months old, so they get 10 points for that. The etiology is post-infectious hydrocephalus. We know those children don't do as well because they have scarring of their prepontine cistern, so they get 0 points for that. They did not have a prior shunt, so they get 10 points, and then the success score is about 20. 20%, which isn't very good. But then you add the CPC and you get about 35 to 45%. But this is a low score because the baby is young, they're little. We know if they're older than 3 months of age, then their rate of success is higher if you can get them to 3 months before you can do the ETV. They're at a high risk of failure because of the cause of their hydrocephalus and their age. They call the office at 1 week and the mom is saying, oh, they're more alert, they're feeding a little bit better, the fontanelle is soft, but it's not flat. It's softer, but it's not flat. And we haven't done any routine imaging yet. Then at 3 weeks, we make follow-up urgently because mom calls and says they're irritable, they're throwing up all the time, they're spitting up after feeds, like both with feeds and long after. They're more sleepy, they're not waking up to eat, and the head circumference is rapidly increasing, and the fontanelle is tens. And then you get a scan, and the ventricles are bigger. But on the scan, you also think that the ETV is still open. So this is a clear ETV failure. We know that this child was at high risk for failure anyways. The findings that suggest failure is that the symptoms never really resolved, right? Like they did for a week. And that might have just been because we let off some CSF in the OR and they recurred very quickly. The finding that's most concerning really is that the baby's not eating, right? And that they're sleepy. In an infant, that's the one that we'd be most worried about, but also that the fact that the head circumference is getting bigger. Failure can be delayed in infants for a few reasons. It can be delayed because if we let off CSF, they feel a little bit better initially, but also can be delayed because the ostomy works at first and then they close it over. This child, that's not what happened. The ETV stayed open, but babies like to heal over whatever you do. So you poke open that hole and they're like, oh, I'll just close that right up there. And that's how they fail. But in this child was at high risk for failure. The factor that worked against the infant the most, the two things were the cause and the age. The factor that made it more promising is that we were able to add the ETV. And what would make the surgeon go to the shunt right now? It's if they go in, they look with the endoscope, and the ETV is wide open, then they would just put a shunt right in. And that is rapid fire case studies for all of you all. I just want to say thank you. Jenny will close up, but thank you all for joining us. Our next webinar is on April 8th, and we're going to be talking about spasticity. And also, please join us or submit an abstract for our conference in October. We're in Cairo this year. There's an abstract submission on the website. We have until April 20th. Likely nurses will have a little bit longer, but that's the website. And we'd be so happy to have you there. Virtually or in person. We do both.
Thank you so much, Ashley. That was a great whiz around. There's a few questions I want to finish off. So can you use this? It will be to everybody. Can you use normal saline in the absence of ringers? Kylie?
We never do, and I don't know the answer to that. I'm sorry. I could try and find out for you though.
Okay. How do you sterilize your endoscope?
Our rigid endoscopes go through the gas sterilizers and steam sterilizer, sorry. And the flexible scopes should all be able to go through gas.
Okay. I hope that answers your question. There's also, what's the lowest age of patient who's had an ETV?
Wait, Norbert knows about the cleaning the flexible endoscope.
Yeah, for the flexible scopes, we have been using Sidex. If you know Sidex, we soak them under Sidex overnight, and we wash them later.
Perfect. Thank you.
And then for the saline,
yep.
For the saline, I think Ringer's lactate has balanced electrolyte composition, which could really be similar to CSF. That's why there is a little risk. It lowers the risk of electrolyte imbalance. However, I've seen saline, normal saline also being used in ETVs, and little has it caused damage to the patient. However, they try to avoid it in operations like ventricular irrigation, where they have to use a lot of fluid to irrigate the ventricles. Thank you.
Okay, perfect. Does anybody want to, Ashley is just answering the question about the age. And so there's a lot of talk about the fluid that we use in OR for ETVs, asking whether this is gravity fed or under a pressure bag. Kylie.
For us, it is surgeon dependent. So I have one surgeon that likes it under a little bit of pressure, and she regulates the flow of fluid with her scope and the taps on the scope. And I have one that likes it gravity fed. And I had another surgeon who no longer works in our department that liked it through an IV line with lots of different types of regulation of fluid. So it's very much user dependent, surgeon dependent. Don't pump up the fluid too high, but it does allow them to have a bit more control over bleeding because they can irrigate a bit more quickly if they need to, if you've got a pressure bag.
Perfect. I hope that answers your question, Aidan. Really good to see people from all over the world popping questions in. Aidan was from Indonesia asking that question, so that's great. And I think that completes all the questions. So at 1 minute over, I would like to really thank everybody for joining us. I would like to thank our 3 speakers, Ashley, Norbert, and Kylie, for their work and their presentations. I believe that this will be available on the ISPN YouTube channel. You can find this in the next few days. It'll be there. And also in the ISPN library. And I've also heard from one of our people who is in the WFNN. And they're putting up on their website as well. So a really good one. I'm hoping that you will all join us in April. And we have another one in June. And then we will have our annual conference in October, as Ashley suggested. So for now, have a great day, sleep well, wherever you are in the world, and we'll speak to you all soon. Thank you so much. And thank you, Christina from ISPN, for managing our Zoom call. Thank you.